Good morning, everybody. Thank you for coming to October's Grand Rounds. Today we have with us Dr. Eisenberg. He is a physical therapist who went for training at University of Pittsburgh and is also a certified athletic trainer. He practices at our Palmer location, and he's one of our outpatient regional directors. So without further ado, I'll turn it back over to Dr. Eisenberg on functional testing for return to sport, work, and life.
So I'm pretty sure Steve has been dreading me having this talk, because I think I was originally set up to do this sometime in mid-2016, and for one reason or the other, he kept pushing me back on doing it. So thank you, Steve, for finally giving me the opportunity to do this talk. I did change the title of this last night because, one of the things, I was thinking about as we were talking about this stuff. Yes, the main topic that we're talking about is return to sport, but really these principles and everything we're talking about today can be applied to returning someone to work, can be applied to returning someone to life. So just a little heads up on that stuff. The planning committee, myself, we have no financial relationships to disclose or anything along those lines. Our main learning objectives for today are basically, one, understand the importance of functional testing. Why are we doing this? Two, how to apply this to our current caseload. Three, what opportunities are there to improve what we are doing with some of our functional testing? Because I think we have a long way to go with this. And finally, what my most important objective for today is to actually get you to do something with this information we talk about today. Because, and Steve probably knows this research, Steve definitely knows this research better than I do, but as we all know, about 90 to 95% of people who sit in a continuing education class never actually apply any of the knowledge that they learn in that class to their actual clinical practice. So what I would really like to see is actually people thinking outside the box and implement and change their clinical practice a little bit, or at least think about changing their clinical practice to apply some of these techniques that we're going to talk about today. So the first thing we're going to ask is, first of all, I'm a very outside the box person. I'm probably a little different, and I probably want to treat this presentation a little bit different from most of the presentations that we've had probably. So, does anyone know what's the #1 risk factor for previous injury? Just shoot it, just yell it out. Previous injury, exactly. And I will admit, I did not originally plan this to be an ACL talk, but we all know that the ACL is pretty much where all the research is for functional testing and return to sport testing. So a lot of the evidence that I'm going to present today is ACL specific, but that doesn't say we can't apply this to other injuries and other athletes or other people who we are trying to return to their activities. So, boilerplate research here. Recent research out of British Journal of Sports Medicine says that people who did not meet 6 return to sport criteria are actually 4 times more likely to get a ACL graft rupture. So that's a rupture of their operative ACL. The flip of the coin there is if you have an ACL injury in your right leg, you're actually at highest risk of getting an ACL injury in your left knee. And I know my personal history of that is I've never, knock on wood, had someone re-rupture their graft on me. I have had in my career 2 to 3 people who have received contralateral ACL ruptures. And I will admit, when you get that initial phone call that they tore their other, or they think they tore their other ACL, it is a sinking feeling in your gut. So that's something that you stick with a little bit, and you try to adjust how you're treating them and adjust your clinical practice in order to prevent that happening in the future. So the biggest things we want to talk about is, why are these happening? Why are we getting this increased incidence in ACLs? in ACL injuries, or why is a previous injury the most likely risk factor for future injury? In theory only, we have incomplete and inappropriate rehab, premature return to sports. You have an athlete who might not be physically or mentally ready, which is a component, and then people who are trying to engage in activity that is too advanced for them to perform. I have always been a believer that as a profession, physical therapists are phenomenal at stage 1 and stage 2 rehab. We are very good at getting our hands on someone, doing a lot of manual techniques, and starting with very basic exercises, muscle reactivation, learning. Once we're progressing past that point, I don't believe, as a profession in general, we do a very good job of pushing our patients pretty hard. We tend to get stuck in the 3 sets of 10 rut. And 3 sets of 10 is not good enough to cut in life. I'm a big believer in that. If anyone, probably the people from Palmer and the people from Quakertown here can attest to this. I am the loud, obnoxious one in the clinic, and I am also the one who makes their patients dripping in sweat by the time they leave. That is my goal. I want people to feel, when someone leaves me for the day, I want to feel that the exercises and the quote-unquote workout that they got from me is going to be harder than what they're going to have to do to get back to practice or get back to work. That is a priority of mine. That's where I think, as a profession, we probably fall a little short. And, I am not hesitant to make someone do 3 sets of 30. I'm not hesitant to strap some weights on people and really get them up and moving. So I think that is definitely a component of why we're getting so many of these previous injuries who are getting future injuries as well. When we're talking about return to play testing, there's really 3 components: isolated strength testing and functional testing. These are very interrelated. These are things, I divided up into categories here, but it's not saying that, a component of functional testing isn't truly isolated strength testing. Finally, and then another component that a lot of times we leave off is subjective questionnaires. So, diving right into it, talking about isolated strength testing. Isolated strength, the biggest thing that everyone thinks about when they think about isolated strength testing, they say it's not functional. True, it is very not functional. However, isolated strength leads to function. So, sitting on a machine and kicking your leg out, not functional whatsoever. However, does the strength you have doing that affect how you're able to do a squat, how you're able to do a step up, something along those lines? Absolutely. So I think it's still a very large component that we're missing the boat on a lot of times. And finally, there are multiple research studies out there that show a very strong correlation between open kinetic chain, isolated strength, and functional performance testing. So some of your hop testing and some of your higher skills testing, there's actually a very strong correlation between how much you can do, how much you can do open chain versus how much you're doing with your foot on the floor. The gold standard for isolated strength testing is isokinetic testing. Unfortunately, we are very fortunate here in St. Luke's to have the $40,000 piece of equipment at our Illick's Mill location where we can send someone for isokinetic testing. It is great. It is phenomenal. It is a monster to house in the clinic. It is much more utilized right now in the research setting, but we have access to it. We should take advantage of it. Usually when we're talking about isokinetic testing, we're talking about we're looking for a 90% ratio involved over uninvolved. So you want to see your involved leg be at least 90% as strong as your uninvolved leg. The other thing specifically with knees that you can look for is a hamstring to quad ratio. Typically what we're looking for in that is about 80%. You want your hamstrings to be 80% as strong as your quads. Typically when we're talking about ACL rehab, everyone focuses on quad, 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 quad. Well, that's great because the quad atrophy, research shows quad atrophies with ACL reconstruction or with ACL injury. However, what actually prevents the ACL prevents anterior translation of the tibia on the femur, correct? What is the muscle that actually prevents it? It's the hamstrings, exactly. The quad would actually accentuate that anterior translation. That's why we need to make sure we're focusing on the hamstring ratio on these as well. Typically what we'll see when we're doing isokinetic testing on someone is this ratio is way too small. It's not 80%, it's 60%, it's 70%, it could be 50%. So something to look at. Now, if we don't have access to isokinetic testing, or your athlete, the patient that you're working with, doesn't want to perform isokinetic testing, can't travel to Ilex Mill, we have a lot of other options. The first option that we have is, probably the most common option, most used option, but probably worst option, is manual muscle testing. Once you get past the 3 out of 5 for any of our manual muscle testing, research is crap. It's basically, it's no longer objective data. It's the clinician's subjective data on whether you're putting a 4 minus, a 4, a 4 plus, 5 minus. Those are all non-existent, really. It is truly, it's good to put on for insurance companies, I should say, but it's pretty terrible from a true objective data standpoint. Something I think we could use a little bit more of, I don't know if anyone has experience with using handheld dynamometers, not the handheld for hand strength, but actually for manual muscle testing. These are called handheld dynamometers, manual muscle testers, something along those lines. Basically, you are doing a manual muscle testing, but they are pushing into that cushion black spot on there, and it will give you a reading of how many pounds of force or kilograms of force you are pushing with. This is a better objective data than a true manual muscle testing, but it is also very clinician dependent. The inter-rater reliability of doing handheld dynamometry is also pretty poor because it's very dependent on how hard you are pushing back against the patient who is pushing against you. The one way that you can use this type of equipment without having that data is having them push it basically against the wall, which works in some cases, or just making sure you're nice and stable when you're doing it, so you're not affecting how much force you are pushing back against them with. The other option that we have that I don't think we use nearly enough is typical strength and conditioning 101. How do you test someone's strength? Is you can do 1 RM, 10 RMs, true objective data. So let's say you have a leg extension machine in your clinic, and you typically have someone doing 45 pounds, 3 sets of 10. Well, why can't you objectify and say, all right, what's the maximum you can do? All right, they're doing 45 one day. Say, all right, we're going to test you today. It's your re-eval day. Why don't we start you with 55? They do 55, they make it through. You're like, how hard was that? It was challenging towards the end. All right, so we're just going to do one little bump up. We're going to try 60 pounds. They get 10 reps there. Good form, no problems. Great. Give them a good rest, 2 minutes, something like that. Let's try 65 pounds. They don't make it through. What's their 10 RM? 60 pounds. Then what you can do, try the other side. This is great. I love to use this for those athletes who say, I'm phenomenal, I don't need to listen to you, I can do this, like let me run right now. I had one recently, a shoulder patient, who was telling me, I don't need to do this stuff, like I can throw a ball, just let me go. All right, let's do a 10 RM. So we did side lying external rotation. So I tested his uninvolved first, and he got 6, 7, 8 pounds. This kid's a horse, he does a great job. I test him on his involved side. He could not get 10 reps with a 1 pound weight. So what did that do? That helped him give the mindset, all right, I'm not ready. I need to pull back the reins a little bit. I'm not ready to do 15 pull-ups and 100 muscle-ups and everything I want to do. It helps set the tone, but we can also use this for a little bit better objective data, I would say. There are other tests that we don't. Has anyone ever used the scapular endurance test? Anyone familiar with it? I don't think there's, well, Steve, that doesn't surprise me that Steve used it. What the scapular endurance test is, you're basically putting someone in a Y position, prone, and you put a cuff weight, which is about 1% of their body weight. So you're usually using a 1 pound, 1.5 pound, or 2 pound cuff weight right at their elbow. They go prone, hold a Y position, have to keep their arm up there, and you just time how long are they able to do that. Test involved, then uninvolved. Typically, you want to see, an athlete, you'd like to see them doing it for at least a minute. Most people will struggle with 20 seconds. The important part to look for in a test like this is making sure they're actually maintaining it, not letting their elbow drop, not letting their wrist drop to maintain the position, but staying up there the entire time. Any questions about that? Any questions about isolated strength testing? So then we're going to talk about some of our functional testings, some of the things we do to really get people back to activity. What are the components of functional testing that we're looking at? We typically look at strength, power, endurance, balance proprioception, dynamic stability, and agility. Those are all components of functional tests. Most of the functional testing that we'll do have at least 3 or 4 of those components, if not more. So some of the functional testing I like to use in the clinic. Single leg press. This can definitely be, we could have a hearty debate whether a single leg press was part of isolated strength or functional strength. Doesn't matter. Either way, you can use it as you can do it 1 RM, you can use a 10 RM with somebody. Single leg sit to stands. If you don't have a leg press, or if you want to see someone really do something functional, have them do this. This is a lot of fun to watch. If you I typically use a low mat or a low chair, single leg, have them sit down, stand up, slow and controlled, lower themselves down. You can calculate the amount of reps that they can do without getting compensations, without throwing their upper extremity forward. You can also see their quality of it. If they are, if you're getting a lot of valgus with anything, if you're getting, a lot of shaking, anything along those lines, you can look at quality in addition to the quantity about how well they're able to do this. And finally, you can do a step over test. Step over test I typically use on the lower end of my functional testing. A step over test is one of the measures I use to tell if someone is ready to return to running. What a step over test is you're basically standing, 2-legged. You tell the patient, pretend you have a puddle in front of you, and I want you to step over the puddle onto one leg. You are basically mimicking a running stride, a short running stride for somebody. And then you're able to see, how are you doing with it? How are you getting, you're looking more at quantity. Are you getting a lot of valgus collapse? Are you having difficulty with stability? Are you hyperextending? Are you demonstrating quad avoidance? Anything along those lines. You can really look at quality. When it comes to my patients and doing exercises in general, I am a stickler for form. I think a lot of times where the PT profession also falls short is we focus on our manuals, we do a great job with our technique there, and then we walk away when they're going to start their exercises because we want to get our documentation out of the way, right? Because we all love documenting so much. Well, really, exercises, I always say, you got to do it the right way. You're here for a reason. I don't want you just doing these for, something in giggles, if you will. We are here for a purpose. I want to develop that purpose. I want you to really work these the way we're supposed to. There's probably one place where you should feel it, and there's one right answer, and only one right answer. You shouldn't feel it. I shouldn't feel it here, here, here. I want you feeling it there. All right, so that's something that I say a lot. So make sure when we're doing these things, you're focusing on form. Don't walk away from someone when you're having them do a step over test or a single leg sit to stand. You can use this not only for return to sport testing, but like I talked about, return to running or progressing along other stages of their functional rehab. Typically, what we're talking about when we talk about return to sport, you want it, like we said before with the isokinetic test, you want to see at least 90% of their uninvolved. Typically, with return to running, I like to see at least 70%. With return to hopping, typically we're in the middle ground. We're in that 75, 80%. I should say jumping is usually 75, hopping, I usually wait till 85. You never want to hop someone a little too early. Another test I like to use a lot is the Y balance test or the star excursion balance test. There was some research here initially that showed that this test was a great way to predict if an athlete was at risk of injury. There are two ways to use this test. There's a way to use this test where you're measuring the difference from their side to side. So the research initially showed that if you had a greater than 4 centimeter difference on their anterior reach and greater than a 6 centimeter difference for either the posterior medial or posterior lateral reaches, that person was at greater risk of injury. I will admit, this research right here, they've tried to redo it. They cannot replicate these results. However, that's not saying we can't use this information and use this data to help us with our current patients in this type of setting. So, does everyone knows what the star balance test is, or star balance in general? All our clinics pretty much have a star on the floor. Basically what you're talking about with this is you're doing an anterior reach, a posterior medial reach, and a posterior lateral reach. We do have 2 or 3 of these kits in the network if you want to play around with the kit a little bit. The other way that I like to use this test actually more is using what they have their composite score. And this test actually allows you to standardize it to the patient's height. So what you take is there's 3 reaches. You take the average of those 3 reaches and you divide it by the length of their right leg. Doesn't matter which leg you're testing, you always divide it by the length of their right leg for some reason. The way that helps is obviously someone who's taller, you'd expect to be able to reach out further. The other reason I like this is you can do the side-to-side comparison, but it also gives you a little bit more objective data that isn't reliant on the other side, which we're going to talk about a little bit later on. But so I usually like to see, initially for return to sport, I'd like to see someone around that 95% range for their composite score. For return to running, it can be a little bit lower. It's about 80%. I want to see less variables, less variation here. We shouldn't be seeing if you're seeing a 60% on this, you really have someone who struggles with their strength, with their dynamic stability, and activities like that. Finally, we're going to talk about hop testing here. Hop testing is typically what everyone thinks of when they think of return to function testing. But I caution people to don't jump straight to hop testing. Make sure they pass all these other components before you start hop testing. You do not want to start hop testing people too early. So typically, when we're talking about knees, there's these 4 tests that we like to use, which is a single leg hop for distance, a single leg crossover hop for distance. The crossover there is 30 centimeters, just so you know, which is the width of two pieces of tape, 2 pieces of athletic tape, I should say. The triple hop for distance, and the single leg 6-meter timed hop test. So typically what you'll have someone do, single leg, and you're measuring from the front of their foot to the back of the foot. And again, on this one, you are very reliant on the contralateral testing. So you're really we'll talk about you're reliant on the contralateral leg. You're reliant on seeing how that athlete measures up to what they're doing on that opposite leg. Single leg hop, you hop 1 single hop front to back. The crossover hop, 3 hops, you have to start on one side of the line, you cross the line, cross the line, cross the line. You want to have your athletes or your individuals hop as far forward as they can while still crossing over the line. If they don't quite cross over the line, that attempt doesn't count. The triple hop is just a straight 1, 2, 3. And the 6-meter timed hop test is running through the 6 meters as quickly as getting through the 6 meters on one leg as quickly as you can. With all of this testing, you need to make sure you are landing with good quality. If you see someone land and shake and fall, that's not an attempt that counts. They need to, quote unquote, stick their landing. The other group of hop testing that's been utilized is typically in patients with ankle instability. So these tests have actually, there's good evidence that shows that these tests can predict someone who has functional ankle instability. You can also use these tests for returning an athlete who has an ankle injury. So you're talking about a single leg figure of 8 hop where you're timing the distance it takes them, the time it takes them to go around. Typically they have to do that in 3 rounds, and you time how long it takes the 3 rounds. The single leg hop, side to side hop, where they're doing, crossing over a 30 centimeter line. The 6 meter, I misspelled meter there. Maybe that's the European way to spell meter. Single leg 6 meter crossover hop test, which is basically a combination of that crossover triple hop and the 6 meter timed hop test. Finally, you have the single leg square hop test that you can utilize. Any questions about hop testing or functional testing there? No? Okay. After, and this is a big key, don't do subjective questionnaires before you do hop testing. Do subjective questionnaires after you do hop testing. It really helps point to the mindset of the athlete and how they felt doing this type of hop testing. All of the questionnaires that you see here do have questions that ask about, pain, giving way, buckling for knee surveys. The Penn Shoulder Score will ask specific questions about instability. These are important questions to gather from them. It points to their mental readiness to get back to activity. I know that we've all had those days in the clinic where we feel like we should have had our psychology degree as opposed to our physical therapy degree or athletic training degree. We need to, I'm probably the worst person around to try to mentally convince someone they're ready, but I think it's something we need to assess. And if we're getting feedback from our patients that they are not ready to get back to activity, we need to find a way to address it. We can't just put someone back on the field where, yes, they might be physically ready, but mentally they're not ready. They're going to fall apart. They're going to forget everything they learned, and they're going to sustain an injury. The evidence on that is pretty clear. Any questions on subjective questionnaires? So, I have a lot of Sethisms that people like to refer to in the clinic. One of my Sethisms is satisfaction is the road to failure. Meaning, if you're satisfied with where you are, if you're satisfied with the performance that you're getting, if you're satisfied with the outcomes that you're getting with your patients, that means you're most likely not trying to get better. And someone else is going to come up from behind you and pass you right by. That is a lot of where we are with functional testing. We have a pretty good idea of what we're doing, but we're not even close to getting the results that we should. And this is some of the things that highlight it. So a recent meta-analysis showed that people who undergo ACL rehab are only have a 65% of returning to their previous levels of sport, and only a 55% chance of returning to competitive sports. If we're sending an athlete to get their ACL completed, and you say, oh, you have a 1 in 2 chance of going back to sport, they're going to look at you like you are nuts. They're like, why am I doing this surgery if I have a 50-50 chance? Well, your 50-50 chance is better than the 90-10 chance you have of not doing surgery. But I think we have a lot of room to grow in this, and we have a lot more room to grow in preventing these injuries. So does anyone have thoughts or ideas? Before I present one of my thoughts and ideas of what we can do better, does anyone in the audience here or on the computer have any thoughts, ideas of how we can prevent I don't want to hear crickets. I also need to get a drink of water out of my lovely Michigan water bottle. And I am still heartbroken about our loss this weekend, but I will still feel true to my maize and blue. No questions here? Let me check the computer. Okay. So, there is a population that we've been doing a great job of returning to sport and returning to activity. And it is not an orthopedic population. It's the concussion population. What did we start doing with them with some of the impact testing and the sideline concussion testing? We did preseason screening. We screen them right after an injury, and then we take their return to play screening and we compare it to their baseline screening, which was their preseason screening. Why can't we take that same thought, that same knowledge, and apply it to what we're doing from an orthopedic standpoint? So what we're talking about doing is doing preseason testing, whether this is completed by physical therapists, athletic trainers, strength and conditioning coaches. The best way would probably be to involve everybody and get everyone involved in some preseason testing. An injury occurs during a season, and then you take their preseason testing results, are basically their baseline tests, and that's their return to play criteria. What is the biggest problem that we talked about before with all of our other testing, whether it's isokinetic testing, other isolated muscle strength testing, or some of our functional testing? With the exception of the Y balance test in parts, the composite score, you are completely reliant on the contralateral body part for legs and arms. Well, most of these people who are at this who are ready to return to play have not been competing in sports for 4 to 6 months, if not longer. So that contralateral leg is already pretty deconditioned. It's probably already fallen apart. It's way behind where it was preseason. That's, in theory, why I think we get a lot of contralateral knee ACL ruptures when returning to play. So if we use something like this, we could actually have a true baseline for these patients. So what can we do for some of our preseason testing? One of the things that's great about this is you can tailor it. It can be sports specific. So if you're talking about your overhead athletes, baseball players, softball, swimming, you can look at their total shoulder range of motion, external rotation strength there. I apparently did not do a good job proofreading. That should be external rotation strength. You can look at their scapular endurance test. You can look at these numbers for not only their injury, for not only post-ops, labral things. You can look for them if you are seeing them non-op. So last year we screened Easton baseball players prior to the season. We kept all their screening forms, so we knew what their motion was prior to the season. I saw about 4 or 5 of them postseason or during the season at some point. They had all lost 20 to 25 degrees of total shoulder range of motion. So we knew that was their starting point. So if you're doing this preseason, you know that baseline measurement, you know that starting point, you can then take that information and apply it to what you're doing postseason or when they have an injury. It can help direct your treatment. It can help show you, where they're at, where they need to go, or, what's changed in their shoulder throughout the season, what they might be doing too much of, what they might not be doing enough of. For soccer, field hockey, lacrosse, lower extremity sports, you can do a single leg sit to stand, you can do a Y balance, you can do a 10 RM leg press, you can do all sorts of good things. This by no means is an exhaustive list of things you can do. This is just meant as something to get your mind going a little bit and some clinical pearls to start getting the ball rolling on these. You can also do a lot of functional testing. So in addition to all the single leg testing that we were talking about before, you can do bilateral things, which is bilateral functional testing, which is how most of these athletes actually play in sports. So you can do a vertical jump. You can do a long jump. You can do a 5x5 pro agility, which shows great evidence because there's a lot of cutting and pivoting involved, which is how a lot of ACLs or ankle sprains occur. And I should preface all of this by saying, the research out there that's starting on some of this preseason testing says that we can do a lot to prevent non-contact injuries. So that's what we're really focusing. We want to prevent that non-contact injury. Can I prevent, that football player who dives right into somebody's knee and takes out their knee? No. There's nothing that, we can do in our profession probably to prevent that injury from occurring. But that cutting, that pivoting, we can prevent the injury that usually occurs from that. There are also things that this opens up the box a little bit for some of our upper extremity sports that we neglect. We can't hop test someone we can't hop test your shoulder. That would be pretty difficult to do. And it's also pretty difficult to do contralateral comparisons on upper extremities because people are usually one hand dominant. So if I have a baseball player who's right hand dominant who had his right labral repaired, and I ask him to throw a baseball and measure how far he throws that baseball, he throws it 100 feet with his right arm and 20 feet with his left arm. Great job, you're ready to return to play. Well, might actually not be ready to return to play because probably preseason he might have thrown it 200 feet. So there are a couple tests here that the evidence is starting to come about that we could actually use this preseason. A single arm seated short shot put. Basically, you have your athlete or individual seated. Their feet are propped up on another chair so they cannot engage their core. It's strictly attempting to isolate the shoulder, and they take a ball and basically shot put it directly forward. You can do a timed push-up where they do as many push-ups as they can complete in 15 seconds. Same things with pull-ups, a modified pull-up. So this is typically a supine pull-up where they're pulling up on a Smith machine, something along those lines. The last one is the Davies closed kinetic chain upper extremity stability test. This was a test that was created and named for George Davies, who's kind of known as a little bit of a quacky shoulder guru. But he's an interesting guy, and this is trying to test a little bit of dynamic stability in the shoulder that we a lot of times don't do a great job of testing or don't have a way of objectively testing. So what this test is you have two pieces of tape separated by about 3 feet. You're in the push-up position, and you basically walk back and forth between those two pieces of tape. See how quickly and how many reps of that you can complete. Any questions on any of those? So another one of my Sethisms that we like to say is we make your life easier by making your exercises harder. And that kind of points to a little bit of, the way we should and the way we could push our patients a little bit. And that, I don't expect them to come in to see me and not leave me sweating and working, especially on these later stages of rehab. The last video I have here is probably what my wife is doing right now, chasing after these two little munchkins. Usually they like to run in opposite directions. She did a good job of trying to capture them in one frame. Usually they're not doing that. And believe it or not, we did not pose them in that picture. They actually ended up like that on their own. He thinks he's a little cooler than he is right there, I think. One thing I always say, questions, comments, or concerns? Steve.
Great talk. One question I had about preseason testing, especially with concussion, this has always come up in recent years. The concern about sandbagging, especially since they know that it's going to be compared. The people who really, really want to return to sport have maybe even been coached to sandbag preseason testing. How do you propose that we address that?
So I would propose doing this the way.
Question, please.
Sorry. Steve's question was, especially with impact testing and concussion testing, athletes have learned or been coached on how to sandbag the test to get lower baseline numbers, so their return to play numbers didn't have to be quite as high. So they could still technically be injured and return back to the field. The way I would propose that we address that is in a similar manner to probably how a lot of if you're treating college athletes, when they arrive on campus, typically they have to do their performance testing, and they have to pass performance testing in order to be allowed to play and participate. So we don't frame it as this is your preseason testing as your baseline. We frame it as this is your performance testing to see how you did with your off-season conditioning or your off-season activities. So we're really addressing more of their performance than telling them it's pre-injury screening or baseline screenings. Chris.
So do you see that with the athletic trainers in our network working with the schools, do you see this something happening with the high school students?
So Chris asked if with the athletic trainers that we have in the network, if we're working closely with those schools and everything like that. The answer is yes, absolutely. We need to do a very good job of working with our athletic trainers. The athletic trainers that we have are a huge asset to our network, and we need to work very closely with them. Typically what I will do is I communicate typically twice a week with the athletic trainers that we are working with. On those athletes that we are sharing, we have to remember that they are the athletic trainers' athletes before there are athletes. And those athletic trainers, they take ownership of their athletes. And we need to respect that and honor that. I leave it up to the athletic trainer a lot of times on how often they want me to see them versus them to see them. So we will work very closely. Typically, I will see the athletes in the clinic anywhere from once a week to once every other week to once every 3 weeks, and then communicate with the athletic trainer what they're doing in the athletic training room, in the gym, on the field with them. So we're all on the same page and working seamlessly together. I also tend to go to, Chris Fisher and I are going to Easton High School this afternoon to screen the swimmers. This is the 4th screening we're doing this year with that school, but we will also go to the athletic training room to triage a little bit and to help the physicians when they're there to help dictate, all right, you need to go to this route, you need to go this route. Any other questions on that, on this talk in general? Comments, concerns? Thank you very much. Oh, hold on, sorry, I did not look to see if there's questions online. No.
And the only thing I'll add is make sure you pick up a certificate, and if you're watching this online, contact me for a quiz. Thank you very much.